It's funny, and we're at a giant cruise port, so it kind of makes sense. But we have a lot of patients who literally tell us, "I want to be able to walk because I miss being able to go on cruises." We hear that a lot, and so it's nice. So when they come back and see us again in, a month, 3 months, 6 months, they're able to resume whatever activity, dog walking, cruising, all the things. And they're not trying to run marathons. They're just trying to be normal people and engage in the activities that they like.
Hey guys, it's Justin and Rachel again from the OBL Marketing Blueprint, and we are here today with Dr. Derek Mittleider of Cocoa Beach, Florida, who has vascular and embolization specialists. And for those who don't maybe know your practice, can you introduce a little bit about your practice and what you guys do?
Sure, and I appreciate the opportunity to talk to you guys today. My practice is I am an interventional radiologist by training, and our practice is, as the name implies, it's a combination of treating vascular disease and a therapeutic embolization, and it's about half and half. So about half of patients we're actually trying to increase their circulation because they have inadequate circulation to their feet. And the other half, we're trying to decrease circulation to areas that are problematic, usually joints that are chronically inflamed, or if they have organs that are causing them problems like the prostate or the uterus, trying to decrease circulation to those. And so that's what the embolization part of our practice is.
It's funny, I've been around embolizations for a couple of years now, but I've never heard it phrased like we're trying to decrease circulation. But I mean, it's essentially what you're doing. So yeah.
Exactly.
And so what got you into interventional radiology specifically, and especially that like in the embolization space?
So the embolization it has rapidly evolved over a relatively short period of time. Interventional radiology in general, I came to that early in training. When you see the procedures where you are able to do relatively to truly complex things without opening anybody up, and with just using X-ray guidance through a tiny little skin nick, it has almost a magical quality to it. Like you're seeing a magic trick. That's kind of what it feels like when you first see it, and it doesn't really go away. There are things that I see to this day that I've seen 500, 1,000 times that are still amazing, and it is not just what you're able to do, but the delivery and the minimally invasive nature of it. And embolization, we've been doing embolization, I think was first reported in the literature in 1971 to 74, somewhere in that area. And initially it was people who had GI bleeds that were not surgical candidates. And so what people initially did is they would take a sample of blood of the patient, shake it on the table until it clotted, and then they would inject that through a small tube into wherever the bleeding was occurring in the body, and they found that it worked. And from that initial experience, it has tremendously evolved over time to where we can treat a growing number of disease processes through embolization. Most recently, we're seeing an explosion in musculoskeletal embolization, knees, plantar fasciitis, shoulders, elbows. There are clinical trials with hands and hips. It's becoming almost endless, the list of things that embolization is going to touch.
Well, and I'm sure you've had that same experience that every one of our providers shares is you have that person that's awake on the table and they're like, that wasn't that bad. What else can you do?
It's a not insignificant percentage of our patients who have a successful embolization. They may have a prostate embolization for lower urinary tract symptoms, and then they're in recovery, or they're there for a follow-up visit, and they see the brochures on the wall and they're like, yeah, I have, pain when I try and move my shoulder. I have adhesive capsulitis, or I have knee pain, or it just tends to, when they have a good outcome with one of them and realize that it is truly minimally invasive, same day in and out type of procedure, it leads them to try it in other areas, and it really feeds on itself.
It's funny because, again, being non-clinical, I speak to like my friends and family about what I do here with the interventional radiologist. And to your point of it being magic, like trying to explain to them, like, okay, they're going to take this little tube and you're just going to be a little injection and your knee's going to get better. And they're like, how soon? I'm like, pretty soon. Like, but it makes believes it half the time.
No, we've had patients ask us after the procedure where the stitches were, and I'm like, well, I can give you some stitches, but you don't really need that.
So talk to me about this trial that you guys are doing at your clinic. What's the RESORB trial? Well, how does that work?
So the RESORB trial is a trial that we just we had our go live this past week, and we are the 12th site in the country, and will be one of 20 or fewer sites in the country that are part of this randomized clinical trial. And the RESORB trial is focusing specifically on a type of embolic, a type of not microscopic but very very small particle that was designed to plug up abnormal circulation and then dissolve honestly within hours of the procedure itself. So we're testing whether it has the same effectiveness as some of the other medication or some of the other things that we use for embolization, with an excellent safety profile, which is what we're hoping will come from the dissolvable portion of it.
Now tell me, what's the rationale behind having the disposable or dissolvable as opposed to what's being currently used?
So if you look worldwide, and there is probably a lot more embolization outside the U.S. that is occurring than inside the U.S. And if you look worldwide, if you're talking about embolizing something that you truly want to kill tissue, like if you're trying to shrink somebody's prostate or shrink the uterus, then having a permanent embolic, something that goes in and permanently blocks the circulation, makes a lot of sense. But if you're talking about something where you're not really trying to kill tissue, like if somebody has chronic knee pain that we know has a major inflammatory component to it, we're trying to attack the inflammation. And what we don't want is to do a good job attacking the inflammation and end up having collateral damage, either damage to the muscle tissue, damage to normal structures, things that people weren't having a problem with and didn't bargain for. And so in the US, for musculoskeletal embolizations, a majority of people who are doing these, like knee embolization or shoulder embolization, they're still using non-dissolvable embolic materials. So things that go in and then stay in there forever. And part of that is our experience, that's what we were trained to use. That's what we use most often. That's what we're most comfortable with. But we know from the data that's been published worldwide that the safest thing to do in those areas is to use something that dissolves. Because in some of these cases, like if you're doing a plantar fasciitis embolization, the tiny tube that you're delivering the particles through, it may be delivering them exactly where you want them to go, but some of them are going to be shed into areas like the toes that you really don't want them to go to. And so if you use a dissolvable, you know that it's not going to be there in an hour or 2 hours, and it's not going to cause any collateral damage. But if you use a permanent, it may or may not, and that's where things potentially are riskier for patients, which is the whole point of this investigation. That it's the first one that is specifically designed to be a very small size, so it can really penetrate where it needs to in a joint, but also go away and not hurt anything else that you don't want it to hurt.
I think from the outside in, me and Rachel get to listen to probably hundreds of patient calls because our team schedules and screens it. And one time we explain embolization, I'm sure you have the same, is people think about, they're going to have something go up and they're going to go into their brain or whatever. That's there forever. I feel like as a provider, you can just say, hey, this is going to dissolve in 60 minutes or 2 hours. Like that's got to put them at ease as well.
I think it does. And I think the fact that, you can use this so many times in so many different areas, these dissolvable embolics, and find that you don't have patients aren't getting, skin changes or skin ulcers or blue toes or anything like that, that the safety profile from something that goes away is very difficult to argue with.
So how would this, let's just say for a GAE, and Rachel and I have seen a couple of these, typically we'll see in a GAE sometimes, some of the blue skin or some of these things. How would the recovery be different with like a RESORB versus that?
So the recovery, it changes how you do the procedure because you don't need to necessarily take precautions that you do with a permanent embolic. So if you've seen people where they put like ice packs on the knee during the procedure, that the whole point of that is they're trying to cause the blood vessels going to the skin to constrict so the beads don't find their way to the skin and cause ulcers or skin changes. If you're using something that dissolves, and we use a dissolvable even outside the trial now, it's not this particular one that's being tested in RESORB, but it's a mix of two medications that when you mix them together and then add contrast, it forms particles. And those particles are dissolvable within hours after it. And so when we do that, we don't have to put ice bags on it. You're not causing vasoconstriction that, at least hypothetically, may limit the effectiveness of the procedure, because if the blood vessels are constricting, you can't get as much embolic in there. And you also have to be more selective in the total volume that you put in. And so it makes you wonder, am I limiting the clinical effectiveness of this because I know that what I'm using is something that's going to stick around and potentially go someplace I don't want?
I mean, I think as a provider, the last thing you want in the back of your head is that, like, am I doing more harm than good? Like, you obviously your whole goal.
Absolutely. Yeah, absolutely. I mean, that's exactly it. That we always talk about complications, and people, that's the whole point of, signed informed consent, that informed portion of it, that you've been told all the scary things that can happen, but it's still, it can be, at least temporarily and potentially permanently life altering for someone if they do have a complication. And so that's why, we're trying to help as many people as possible, but we're also trying to tread as lightly as possible, so we're not just leaving a path of destruction in our attempt to relieve people's knee pain.
Well, and I think you even said earlier, like, this has been the whole Department of Interventional Radiology, is how do we continue to mitigate the effects of these procedures? Originally with stitches, now we're looking at this, but if we keep making it, have a better safety profile, that list of potential possibilities isn't as big, and it makes it a lot easier for everyone to adopt.
That's absolutely true. And I think you see that not only mixing up what we're using to perform embolic procedures with patients, but how we even get there. That historically everything was done through groin access, like from cardiac casts to IR procedures to vascular surgery procedures. They were all done with groin access. And now you're seeing people migrate to other sites of access, not necessarily for peripheral embolization. But when we do shoulder embolizations, we use radial access from the wrist. When we do knee embolizations, the majority of the time now we're using pedal access from the foot. And patients, it's safer for the patients, and that's what the data unequivocally says. Patients prefer it, and it also gets them up and about that much faster. They're not limited by groin pain. They're much more mobile, much more quickly.
Rachel and I were at a conference about a month ago, and the provider that was speaking was like, if you've ever tried to do a groin access on someone that's 300 plus pounds, he's like, what the lift than just going from the foot. So definitely an option there for certain people as well.
Absolutely. And it is unequivocally safer.
So talk to me about, this is kind of a blanket question, but since you guys have been doing the embolization procedures, whether with RESORB or not, what has been your favorite, like, outcome to watch? Like, who is that patient that you see them come in and you're just like, man, their life has changed when they walk out the doors?
So the ones, honestly, are, we see a lot of patients who have been told that they have basically burned all conservative treatment bridges. They've either had so many knee joint injections that they really shouldn't be getting any more, or they've had so many injections into their plantar fascia that they risk getting a plantar fascia rupture. And they've tried everything short of, in the case of knee embolization, short of having a knee replacement. And there are many reasons why patients either can't get a knee replacement or simply choose not to. And the can't can be their size, that, it can be that perpetual spiral that if your knees hurt so much that you can't walk, then it is easier to get larger and it's harder to get smaller. And, you go to your PCP and your PCP is like, you need to lose weight and exercise. Well, if you have advanced osteoarthritis, that's very easy to say and very hard to do. And so these patients, if they exceed the thresholds for having orthopedic surgery, then they don't have that option. And there are, I would say, we see a lot of patients who are outside that threshold to have knee replacement surgery. And we also see a lot of patients where the time and effort put into not only the act of surgery, having their knee replaced, but that recovery period where they have to have physical therapy 2 to 3 times a week for months after the procedure, and all of the devices that they have to get, either rent or buy, to help them recover. It's a massive undertaking. And to have paid time off from work that allows you the time to do that is a less and less common thing. And so we hear it all the time. People simply say, I can't afford to get a knee replacement. Not just the doctor bill from the replacement, which is not cheap, but also that entire recovery period. I treated a patient last week who was a bartender, and I treated a patient not too long ago who works at an airport. He's the guy out there waving the wands when they're pulling your airplane in. Like, this guy needs to be and is on his feet all the time.
Yeah, we need that guy.
Yes, exactly. Especially right now when so many people are calling out sick and flights are being delayed. So these are the patients that if you can get them back to being able to move and do so quickly and do so without all that added burden after the procedure, it is life changing, truly life changing. And the fact is, the vast majority of these patients respond to this treatment. That if you look at the published data, the outcomes, patients who say that they are satisfied with the procedure, not just a week later, a month later, but 1 to 2 years later, it exceeds 80% in most published cases. And so you're talking about a massively effective thing. Nobody gets a knee joint injection, and 2 years later is still really happy that they had it. It just doesn't last that long.
I might secretly be in a Facebook group for knee replacement patients just because I like to watch. And it's funny because, I mean, a lot of them eventually will need the other one done. And no one's like, oh, yay, this is, we're going to go get this done. I'm going to go see my doctor. It's just this dread of, here we go again. And so it's just funny because, like, I've interviewed patients that are coming in for their bilateral. I have a clip I've played at OEIS with this woman, like, I'm getting this one done today. And she's excited for it because it's not a big deal.
No, and they really are. They come in excited about it. That's absolutely true. Nobody's excited about it.
Yeah. I love that you talk about, the patient that's told, hey, you need a knee replacement, that's your last option, but you're going to have to lose a lot of weight before you can do it. And the struggle with that, right? Like, we all know the GLP-1s and weight loss is like a huge thing right now. And I've heard stories and seen patients go in for GAE just to say, hey, I got to get moving. Like, my doctor says I have to lose weight, but I physically can't even walk around the block without crying and in so much pain. So they go through the procedure, they get GAE done, they start exercising, they're more mobile, they lose the weight. And they're like, then you follow up with them 6 months later and they're so excited. Oh my gosh, Rachel, I've lost 50 pounds. I feel amazing. I can walk and go on trips. Okay, when are you having your knee replacement? Oh, I don't need that now. I'm good. Like, they don't feel the pain anymore. I'm sure eventually they would need it, but it's not even in their vision now, where they came in to get GAE to get the total knee. And now that they don't need it, they've lost the weight, they're mobile, it's out of sight, out of mind. They're like, oh no, that's not even on my list. I don't even want to do that.
No, you're exactly right. It's ultimately about quality of life and improving quality of life with a minimum of risk, and in doing so in a financially prudent way. So you're not really bankrupting the system. And I don't know if it's true or just one of those stories that gets passed down. But the people used to talk about how the early data on knee embolization came out of Southeast Asia, and people would talk about how the fact that there were simply so many people that it would overwhelm the orthopedic community there. So they were looking for alternatives to joint replacement, and that's where the early interest in this came back in the around 2011 is when they really started looking into this with vigor. But many of our embolization procedures were simply exactly as you described. They were preoperative. Uterine artery embolization was done in France as a pre-hysterectomy procedure. And what they found is a segment of people stopped showing up for their hysterectomy. The same with prostate artery embolization. It was done for bleeding, and people found that they could pee better also. And so it's just, you end up doing something to facilitate a more invasive thing, and then you find, well, maybe I actually don't need that more invasive thing.
Well, I think something that we get to see is, we do obviously our marketing. So we're on Facebook, which is probably not where most providers are at. And so we bring in a different population. And I can't tell you the amount of texts I've gotten from a doctor that's like, hey, your GAE patient came in with a black foot today. But that being said, the amount of times that someone's gotten a GAE that's helped their PAD or vice versa, they've come in for this, like, it all works together for this better quality of care.
Absolutely. No, it totally does. And I think that and that was one of the major eye-opening things with our practice when we started the relationship with your practice, was there is a huge cohort of patients who are out there that if I'm just using all the types of advertising or types of patient outreach that historically we would use, I would miss them, or I wouldn't have the impact that your company is able to connect to these patients in ways that I would not be able to do so. And I think that is where the synergistic effect is tremendously beneficial for patients out there who just want something that makes them feel better and able to do the things they need to do.
So talk to me about that contrast you just brought up. So at this point, traditional, marketing for a clinic or referral, getting referrals from providers, as opposed to going directly onto someone's iPhone or whatever it is. How has that felt different and contrasted with the way the patients come in and are just ready for being with you?
I think a lot of it is it seems to me, as somebody who has no particular expertise with the platform, it seems that it allows patients the kind of the early insight into something where they can actually ask questions or explore it further before they're necessarily put in a clinic room with me or with my nurse practitioner, where then it's similar to people like to maybe wander around the car lots on Sundays when the car lot's not open because nobody's going to jump on you and then trap you in a room and so you're a salesman, doctor. Is that what you're doing? No, I'm saying you're the opposite, that you allow people to open the car doors and check out the car and smell the upholstery and see it and feel it before they are, stuck with me to where it may be a different sort of pressure situation. That they can have conversations, they ask questions, they offer insight that they may have heard from other people. It's much more of a kind of community conversation than any other type of advertising that I've been exposed to.
I love that analogy. I do. I'm going to use that. Yeah. I think what makes it simple for the leads, the clients that come to us, right, is we're speaking layman, like we're speaking in non-clinical doctor terms, right?
Yeah.
Where I think that's where they connect more. And I mean, even saying like interventional radiology, every person on the phone's like, who, what is that? It's like, oh, like just talking in a manner that they're going to understand, right? Where it's just like layman's, I don't know what the word is for it without sounding offensive to anybody, but just like you said, community conversation, and then coming to you, it's that higher level clinical, okay, let's go through the risk, let's go through everything that, we really need to. But I think that's where people get really comfortable and they come in and they're ready. Most people, right? They know everything and they're like, just sign me up. Am I good? Can I get this, please? That's
Exactly.
cool.
And a lot of them do their own research, which we never discourage. And with anything that's out there, you can always find people who did not have the best outcome, or find people who are not fond of it. But in this case, the majority of the people, especially those who've actually gone through it, they do endorse it and they are happy with it. And so that kind of, once they kind of, it is similar to how when society was a little bit different and people were in more social settings more often, you had kind of that community chatter that would give people opinions about things because they were interacting with people that either by the sheer numbers that they would hear of would kind of make them trust it more, or they would be people they trust who were telling them, yeah, I had this done. And so I think that's what this platform that you offer allows, is them to get exposure from people who aren't trying to sell them things, and meaning the physician or the physician's practice, and to get input from people who they trust because they know them or have similar experiences, whereas me, they probably have not met yet, and we don't necessarily have the same experiences.
You said something that's been a kind of a mission of Rachel and I's over the last couple of months, and we're going to keep pushing it. It's hard because we work with so many practices, but like we want to have so many testimonials for the procedure, maybe not even for the doctor perspective, but I'm talking to someone for your clinic and she's a GAE candidate and she's 65. I want to have a 65-year-old GAE candidate testimonial that I can send her, even if it wasn't from your place, just to say, look, people just like you have had that. And so that's been kind of our mission, to start gathering those, because it just makes people feel safe to know other people just like them have had it.
I completely agree. And I think medicine is scary. Nobody wants a procedure, but people want certain outcomes. And I think that if we can present it in such a way that they can see that you have the possibility and the, not, I don't want to say likelihood because that's a bit unfair, but you are more likely than not to get this outcome, and to do so without somebody coming at you with a scalpel or stitches or anything like that. It kind of de-stresses the entire scenario, because when you're talking about open surgery, especially talking about joint replacement, that's a massive undertaking. And it is, there was a Washington Post article that was fantastic about a year ago, where it was the author of it was a journalist who underwent knee replacement. She was a runner and highly active, and she kind of admits through the story that she didn't really understand what she was getting into, and she ended up interviewing with a lot of other people who had similar sort of experiences. And she concluded the piece by saying, if I knew now the experience that I have had, I would not have undergone that. And you don't meet many people who have had a joint embolization who say, I wish I hadn't done that. It may not work, but it's such a low risk and such an relatively easy undertaking that if it doesn't work, you haven't burned any bridges, and it's not hellaciously expensive like joint replacement is too.
Well, something that you said earlier too is like, as a provider, as the clinic, you guys are busy. Like you're doing medicine, and I would tell you, because we have a whole tool that analyzes our clients' calls and stuff. And one of our big key points is, are we hitting on the emotion of what do they want to do? If your knee's feeling better, what's the thing you're going to do? Because all they really care about when they come into you is, can I walk my dog again? They don't care what the blush looks like or any of that stuff. They just want to know, can you help me? And so we spend so much more time on that than the actual medicine, because we're not clinical, and that's why people show up.
Yes. And it's funny, and we're at a giant cruise port, so it kind of makes sense. But we have a lot of patients who literally tell us, I want to be able to walk because I miss being able to go on cruises. We hear that a lot. And so it's nice. So when they come back and see us again in, a month, 3 months, 6 months, they're able to resume whatever activity, dog walking, cruising, all the things. And they're not trying to run marathons. They're just trying to be normal people and engage in the activities that they like.
So
just came up with an idea, and we can cut this if we need to, but we could run a GAE clinic on the next cruise out of Cocoa Beach or wherever you are. You can all come set that up.
Rachel's not advocating we do medicine in open waters without regulations. Okay, that's not what she's saying.
I think the rules are really gray in the waters. It's fine.
Well, that kind of brings me to my next question, was just looking ahead at what's coming down the pipeline in embolization, for either MSK or disease. What excites you? What's something you see that gets you going?
The things that I get asked the most about when I give embolization talks, and you never really know what people are going to respond to until you put stuff out there and just let them talk and tell you what hurts and what they wish you could embolize. And the two that are the most commonly mentioned are hands and hips. The hands has really surprised me, but people are truly limited by osteoarthritis of the hands. And there are clinical trials that are ongoing with dissolvable embolics, more outside the US than in. And the data is no less impressive for that. It's too early to start doing anything like that here yet, but it will come, it will happen. And if it plays out as the early data shows, patients are going to be very happy, because they have no good options for that right now.
Rachel and I actually just got to interview a patient about a month ago that she was a pianist, and she had gone through the hand embolization and regained the ability to play her piano. And I was like you, I didn't even know that was a need, an issue, but it was just crazy to see how much it affected her life.
Yeah. And it's
actually interviewed a couple. There was another gentleman who was a mechanic, and he couldn't hold his tools anymore. And just something small, right? Like holding a screwdriver or twisting something like that. And it was in his thumb, mainly in his thumb. And it was life-changing for him just to do that. And he was so excited to talk about it.
It's one of those things that if you don't understand the importance of it until you can't do it anymore.
Yeah.
And when you hear about it, like putting particles into your head, it sounds like this is not going to be a good idea, but if you use it dissolvables, it really works. And I think that is a very exciting frontier for this sort of medicine.
We're excited about hands. Hips, I have some questions. I feel like when I ask providers, because believe it or not, our leads come in, we have a lot of people ask, will this work for hips? Will this work for hips? And there's not a lot
I
of
believe it.
IRs or vascular surgeons that we have found that will do hips or feel comfortable doing them. I don't know if it's because the risk factors or the studies, like you mentioned. I don't know why more people aren't doing that.
The hip has a special vascular supply that there is a particular artery that if you were to put embolic into it in a considerable volume, you could actually cause the entire head of the hip to die. And as you can imagine, that would be a devastating complication. You would basically push that patient to where then they would have to get a hip replacement. So I think that's probably the component that is, frightens people off from it. Yeah, but I think we'll get there. I think it's just going to take the right embolic and the right kind of technique, because if you look 20 years ago, nobody was doing any of this. And now we've come so far. And I was even commenting to my lead tech the other day that if you had taken people who came out of training at the same time I did, including me, and asked them to name all the branches that we're routinely embolizing on a daily basis, they would have been able to name almost none of them, because you would have to look up in a textbook because they were of no relevance. You just weren't doing this sort of thing very often. Like occasionally you would get somebody who came in for repeatedly bleeding into their knee after a knee replacement, or bleeding into their shoulder because of trauma, but that was not a common thing at all. And so this whole world of medicine has just come upon us so quickly.
Well, it's interesting. I mean, I've only been in this specific field of IR in like the last 3.5, 4 years. And I remember being at OEIS, I think probably when I met you and Laura the first time, that was maybe 2 years ago. And like, I would say 60% of IRs were like, we don't touch that embolization stuff. And now I feel like it's shifting where there's a couple small guys doing PAD and veins only, and everyone else is shifting into the embo. So it's crazy to watch the industry change.
It absolutely is. And I think you really, it's the patient outcomes that drive this, that the patients they're hearing about it from their friends, or they're seeing about it on Facebook from you guys, and they want it. And we, as you know, we get inquiries from all over Florida because there's such treatment gaps, and those gaps will close. It'll take some time, but I think you are going to see people flooding into this space.
Now, just as we're wrapping up today, one thing for anyone that's watching that's a provider, where can they follow your work and stay updated on the research and what's coming out from your team?
Yeah, so honestly, the best repository of all of our stuff is our website. We try and keep it updated fairly frequently. We use OBL Marketing, who are great, and it's vasculaремbo.com. They made a beautiful website for us, updated with our clinical trials this week, and well, a lot more to come.
No, those are good guys. Well, awesome. Well, hey, doctor, I really appreciate your time today. This has been awesome. I don't know about you, Rachel. I also learned a lot more today than I expected.
I did too. Yeah.
All Snapple nuggets of the history of IR and EMBO. So this is awesome.
Love it.
Well, doctor, I really appreciate your time, and we'll talk to you later.
Thank you. I appreciate the opportunity. It's always nice to talk to you.